Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, happy February, everybody. This is Terry O'Brien, the producer of the Metabolic MD /CGM Doctor. I'm here with Dr. Paul Kolodzik, the expert in the areas of GLP-1, CGMs, and all kinds of great medical advice. Hello, Dr. Paul.
Thank you. Metabolic health medical advice. I don't offer medical advice in every field, Terry. I know you probably have that impression of me that
I do. I have some feet problems that I'd like to talk to you about.
Okay. All right.
Okay. So we have kind of steered away from the topic of GLP-1s for a while because we've been focused on all the great things you can do with CGMs, right?
Because they're now over the counter, don't need a prescription.
Right.
So that's always been the foundation of the practice. So, yeah, we've been focusing on that recently.
And there are two websites that people need to know about before we jump into the topic of GLP-1. That is Metabolic MDs. Go ahead and give them that website. MetabolicMDS.com, which is for patients that I can people I can treat as patients in the 4 states I'm licensed in: Ohio, Indiana, Florida, and Arizona. And then for people that are not in those states but want to experience the value of a CGM, they're now over the counter. You can get them without prescription, and we offer that and information on how to use them effectively. Health coaching at cgm-doctor.com. Doctor spelled out. That's a good plug. I like to give you a plug right off the bat.
Can I plug the book too?
The hell no.
Okay.
We'll end with the book plug.
Okay.
Excuse me. So first thing I need to mention is, when GLP-1s first hit the market several years ago, they were hot. Everybody was using them. Hollywood elites were on it and all that kind of stuff, right? They become so mainstream now. This is no longer the mood ring or the pet rock. This is serious stuff. And people are taking advantage of all the positive things that a GLP-1 can do. And that's kind of what we're going to talk about today, correct?
Yeah. I always, these medications have been out for, a decade and a half or so. We don't know all the long-term side effects.
We've really only started hearing about them 3-4 years ago. People didn't know that all this stuff.
Yeah, but they've been used for diabetes for close to 15 years now.
Okay, but the weight loss aspect of that was not really...
Right, okay. Exactly.
Yeah,
2 or 3 years. But again, first do no harm. Let's make sure that there's no long-term effects. So this kind of goes to the theme that we're going to talk about today, which is, they're effective medications. They've got a lot of new indications, reasons that people might want to be on them. But lower doses for limited periods of time, I think, is still the most prudent approach. And that's what I build when I prescribe these medications. I build my practice around because, there's a lot going on out there with internet availability of these drugs. And, one of the dirty little secrets in medicine, and it's not only this area, it's like, let's get a patient on a medication and let's keep them on that medication for as long as we can, because then we have a patient and, to be blunt, a revenue stream from that patient forever. So, I'm at a point in my career after being in the emergency department for 30 years where I just really want to be able to use these medications effectively and have people come through the other side with improved health. So people need to be aware that there is a profit motive out there for a lot of the companies that are providing these medications.
So you talked about indications for other uses of the GLP-1 semaglutide medications.
Yeah.
Now, the first question I have after that last statement is, are they coming up with other things that could be used for as a revenue stream, or is there actual some Harvard studies that are finding these things?
Well, so understand, the pharmaceutical industry invested billions of dollars in creating these medications.
Sure.
And so they are constantly doing additional studies looking for what's called new indications. The word indications is a fancy term for reasons doctors can prescribe these.
So is this a serendipity thing? They start putting it on for weight loss or for diabetes, and they notice that these other things are happening?
Well, that's actually what happened. Initially, a drug for diabetes noticed that people lost weight on it. But now noticing with more and more people on these medications that they improve other conditions. So let's talk about a few of those examples.
Please do.
Okay. And this is to the point where some insurance companies and even Medicare, which is historically very restrictive related to potential obesity treatment, is saying, oh, yeah, we'll pay for that. And let me give you an example. If you've had a cardiac event, a heart attack, and you're
I have.
And you have, yeah. And you're obese.
I'm not.
Right.
I look like some type of Dave Draper or Arnold Schwarzenegger. Yeah, go ahead. You don't know it.
I don't even know how to respond to that.
Go ahead, keep going.
Okay. But so initially, if you're a Medicare patient, you could get this drug for diabetes. You still cannot get it for only obesity. But now, because this drug has been found to help with decreasing the risk of a second cardiac event after you've had a first cardiac event, Medicare has approved it for patients that have had a previous cardiac event and obesity. Okay, so it'll be covered then. And as the pharmaceutical companies are doing, more and more studies to say that this drug will help with this condition or that condition. And some of these have been accepted by the FDA and approved for that indication, and some of them are still in process. But I thought we should talk about some of those other ones.
Go ahead. Go.
Fatty liver disease.
Now, is that really the top of the line fatty? Because you never hear
one in 5 older Americans. Yeah, I see it all.
Do people die of fatty liver disease?
Absolutely.
Really?
Yeah.
I've never heard that.
It can cause liver cancer.
Liver cancer. Okay.
Over a period of time. So again, fatty liver disease is just basically fat being deposited in the liver, and where that comes from is what we've talked about over and over again. Your blood sugar's high, you're diabetic, you're pre-diabetic, you have some insulin resistance, your blood sugar is at a higher level. That blood sugar can't be absorbed by your organs like your muscles for energy because there's excessive energy around in the form of that high blood sugar. So the extra blood sugar goes to your liver and gets converted to fat. Some of it gets deposited around the middle, but some of it just stays in the liver.
And how do you test for fatty liver disease?
Well, there's a variety of ways, but where I see it almost every day is when I do CAT scans of people's abdomen in the emergency department. They come in with abdominal pain. It's usually an incidental finding, meaning nothing to do with why they're there at the moment.
Yeah.
But the radiologist will comment on incidental fatty liver disease, which basically means where there should be liver tissue, just liver, the liver is infiltrated with fat throughout it.
Wow. Okay.
Yeah. Yeah, 1 in 5. This is a big issue. So GLP-1s have been found to decrease fatty liver disease. So we talked about decreasing risk of a second heart attack.
Right.
So, and we're going to come back to a theme because I think all this relates to largely GLP-1's ability to lower blood sugar.
Yeah,
okay?
I was
so
hoping you were
going to come back to that.
Okay.
So another one is sleep apnea. Okay. Recently indicated to reduce sleep apnea. Well, that makes sense, right? Because if usually people that have sleep apnea are overweight, you take a GLP-1, you decrease your weight, your risk of sleep apnea goes down, or your condition of sleep apnea can be reversed.
And that's where you wear the mask at night? Is that what sleep apnea? Okay.
Yeah. So basically what happens with sleep apnea is your oxygen in your system drops overnight because you're basically having problems getting air in a routine manner associated with snoring or relaxation of the glottis area of your neck.
I was just going to say the glottis thing really I have no idea what the hell glottis means, by the way.
Okay, your laryngeal area. Larynx?
Thank you.
Okay. All right. Another one that is under a lot of research right now is dementia.
Yeah, that's the one I just heard on news like 2 nights ago.
Yeah. So, and Alzheimer's disease.
Aren't they? But they're not the same.
They aren't the same, but there are common mechanisms for them. For example, high blood sugar. Diabetics have a higher risk of both of normal cognitive vascular dementia and then also Alzheimer's disease.
Yeah, okay.
So GLP-1s are thought maybe to decrease that risk long term as well. Again, makes perfect sense because diabetics have higher risk of those cognitive problems. You're maintaining a more stable blood sugar. You maybe have had sleep apnea and your oxygen delivery is better to your brain routinely. So yeah, you would expect that risk to go down.
Can I ask a quick emergency room question for you?
You may.
I'm sure you've had people come to the emergency room and then you've noticed that maybe they're experiencing dementia or Alzheimer's.
Yeah.
What do you normally suggest that they do?
Very tough situation. Okay. Because, in the emergency department, where we can intervene is an acute event.
Meaning a heart attack, something,
or
gunshot.
or a stroke, or abrupt change in what we call mental status, where the cognition has changed within a matter of a few days.
Right.
Okay. And so we can address that, intervene, admit the patient to the hospital for more testing. But the more common situation is this gradual progression that has occurred over months to years, where finally the family, the person can't take care of themselves anymore, or the family, is becoming more and more concerned, and that's more difficult from an emergency physician standpoint because you don't have a hard, immediate, emergent problem to admit the patient for.
Right.
So, what we do admit people for safety reasons. Okay, this person now is not turning off their stove. So there is that consideration, but that's always a harder problem to solve long term because sometimes the hospitalists, the doctors that admit patients to the hospital, they don't want to admit somebody if they can't intervene in a medical manner.
Right.
And then you get into this situation. This happens almost every day where you have a patient that's just been getting worse over a period of months. And then the issue is really you're talking to the family. We can look at admitting this person to the hospital with this gradual decline. We haven't been able to find anything abrupt, no emergency condition, nothing that can be reversed. Do you want this person potentially admitted to a rehab facility? So they lived in their home for the last 35 years.
Yeah.
And now we're talking because the family doesn't feel they're safe anymore. Maybe they're having some falls and at risk for that. Bringing them in. I can't find a medical reason to admit them to the hospital, but the out is, we can admit them to the hospital if you're willing to consider placement. And rehab facility is sometimes a euphemism for, nursing home.
Oh, yeah.
And, somebody's been in their home and independent for 35 years. That's a tough decision.
Oh, I bet it is.
And then the outpatient evaluation of that issue, the gradual dementia issue, is called a comprehensive neurocognitive evaluation. And that involves not only neurologists, but sometimes psychologists. So it's a very comprehensive evaluation which can take multiple outpatient visits and, sometimes a number of months to sort out.
So you wouldn't just do a CAT scan? You see
we do
plaque on the brain and you go, okay, this guy's got...
Yeah, but yeah, there's that plaque on the brain now, and it's probably been there for the last 4, 5, 7 years.
But so plaque on the brain doesn't necessarily mean they're dementia.
No, I see a lot of patients that have vascular changes, plaque on the brain that are still cognitively fine.
Okay.
They're just at risk going forward.
Have we missed any? I'm sorry for the diversion, but have we missed anything on the hit parade of things that can improve?
Yeah. So, obviously a lot of things associated with being overweight as well. So
that's the number one thing it's kind of being marketed as, isn't it?
Yeah, and this comes back to the issue of, if you can control your blood sugar long term, then you can avoid a lot of these problems. There's some indication now that there may be some cancers, and this makes sense. You think cancers grow because they have a supply of nutrients. If your blood sugar's high, that's an excessive supply of nutrients. Keto diets have actually been looked at to help control the growth of tumors.
Oh, wow.
So you think that could that inflammatory process and that increased blood sugar nurture the onset and then the growth over time of cancers? And the answer is yes. So GLP-1s are looking at that as well. Psychiatric problems, another part of my life, addiction management.
Oh, yeah, I've heard about that, where it can also help alcoholics.
It helps out. We talked about that previously in a podcast.
Right.
Yeah, and my patients that I do have on GLP-1s, don't necessarily come to me for alcohol-related issues, but their alcohol almost routinely drops. Their alcohol
by
use.
A lot, by a little, by
very significant. I've had people that are drinking. We measured in drinks per week, or drinking 10 to 15 drinks per week that go down to a couple drinks per week.
Wow,
it's really remarkable. Now the problem is that if you have a slender person, you can't really put them on a GLP-1
right
for that. But if you have a patient that's overweight and maybe their excessive alcohol use is contributing to them being overweight, then that can be helpful. And this is I love those patients because it's right up my alley, being board certified in both addiction medicine and preventative medicine.
That's actually a really cool area that if you could help people get off either drugs or alcohol,
yeah,
and it has all these other positive side effects, it could be just like the coolest thing ever, right?
Yeah, it's great. It's great. It's very satisfying when
Right.
you have a patient like that.
So, but when you prescribe people who are overweight, you're not saying I want to put you on this for life.
No, so that really I think is the crux of the matter. The Metabolic MD side is, we advertise reset your health and your weight. And I think these medications should be used as a reset. So the way I have always used the medications, whether it's the brand name or the compounded medications, is lower doses for limited periods of time. Begin with the end in mind. Try and measure the use period in months, not years.
Right.
And institute all the other lifestyle changes that you need to make during that period of time, primarily related to low carb diet, intermittent fasting, and strength training. And that's why I love to pair the use of GLP-1s with continuous glucose monitors, because I really think that's the most effective way to be successful with your GLP-1 and then eventually get off your GLP-1.
Do you recommend the fact that somebody should wear a CGM for a couple of weeks before you put them on semaglutide? Because of the fact that they don't know how it's affecting you, but you can see it when all of a sudden you start to inject this stuff?
Medicine is diagnosis and treatment. So you want to diagnose to begin with. So as many patients as possible, I will put a CGM on them for a few weeks before they start their GLP-1. We'll do a fasting insulin level. We'll determine an exact level of insulin resistance. We'll see what their blood glucose patterns are, and then we'll get them started on the GLP-1. And then a lot of times the GLP-1 brings down your blood sugar,
right,
smooths out those curves. So for a period of time, they might not need the CGM while they're on the GLP-1. But then, because this is a medicine that's titrated up over time, and then when you're ready to come off, titrated down, as they're titrating back down, the CGMs become very useful again. because then they can begin to follow those patterns. And as their medication use is coming down, they can see the foods that might be bumping their blood sugars, and this can help guide their low-carb diet.
All right. Have we left anything off your list?
No, I don't think so, other than, I mean, the global picture here is that, you know, the GLP-1s are here to stay. As I've said before, the genie's out of the bottle. The drug companies will continue to find more and more indications for these medicines. Payment is always an issue.
Sure.
And that's why we do provide the compounded GLP-1 medications for patients that don't have insurance coverage. The best route to go is a branded name.
Sure, absolutely.
You know, because if insurance will cover it, but that is still limited, and that's, you know, a global issue our society is going to have to deal with, figuring out how we can afford, you know, these $1,000 a month medications for a large percentage of the population with all these new indications, and that's why.
Well, I've heard they're starting to come out with lower cost.
Yeah, there are lower options that the drug companies are developed. For example, one of the drug companies has developed a plan where we aren't going to give you a pen, we're going to have you draw it up in a vial like the compounded medications, and we can cut the cost in half or so. So we're involved in all of those programs to get people medication the most effective way they can. But I think the compounded medications that are about a third of that $1,000 cost a month are going to be here for a while. But the issue is, let's not create lifelong dependency. Let's go in here with a plan, with lifestyle changes, diet, exercise, fasting, get you on the medications, get this reset, and then eventually get you off the medications with you continuing those lifestyle considerations without the need for medication.
All right. Well, we're going to end this podcast, but I do have an idea for another podcast down the road.
All right.
Because I'm a diabetic on insulin.
Yeah.
I would love to talk about, is it possible for somebody like me to get off of insulin and go to a GLP-1? We'll cover that in a different podcast because I got way too many questions for this one.
The answer is yes. Okay, I've gotten a lot of patients. We don't talk about this, but you know, I've got and it's common. I call it putting diabetes in remission. I don't say that you're cured of diabetes,
right? But
I've gotten a number of patients that have been insulin dependent off insulin, primarily focusing on these lifestyle factors that we talk about.
Well, we'll cover that on another podcast because I'm very interested in that topic. All right, this has been the CGM/doctor.com, right? I want to make sure that's the website.
CGM dash, not slash, Terry.
Slash is a guitar player. I'm sorry.
CGM dash
doctor.
Spell out doctor.com.
Spell out doctor.com,
yeah.
And the Metabolic MDS.com.
For the patients. And then, of course, we haven't talked about the book in forever, Terry.
Let me look at the time. Oh, hey, wish we could. Time's up.
Okay, check out Amazon, The Continuous Glucose Monitor Revolution for Non-Diabetics, best-selling CGM book on Amazon.
All right, folks, that has been it for the CGM Doctor/Metabolic MD. I'm Terry O'Brien, your producer. Thank you to Dr. Paul.
Thanks, Terry.